consequently, when the dentures are made, the position of the upper anterior teeth will be altered to modify the degree of protrusion. Measurements of the depths of the periodontal pockets must be made so that the amount of alveolar bone resorption can be estimated. The dentist will then know how much more bone should be removed by alveolectomy in order to reposition the teeth and accommodate anterior labial flanges. To obtain a final assessment of the condition, pocket depth measurement should be combined with inspection of the radiographs of the anterior teeth. It will be seen that bone has been lost to such an extent that only the apical third of the roots of the teeth are held in bone. The initial clinical procedures, preliminary impressions, working impressions, and recording the occlusion, are carried out in the usual manner. After the occlusion has been recorded, the models are mounted on an articulator and the technician sets the posterior teeth into occlusion. The relationship of the posterior teeth to the tongue and cheeks should be indicated by the lingual and buccal shaping of the back blocks. At the next visit of the patient, the partial wax dentures are tried in the mouth to check the recording of the occlusal relationship, the shade of the teeth, and the position of the teeth in relation to the surrounding musculature. In order to compensate for the small degree of reduction in vertical face height that has followed the loss of the posterior teeth, a small increase in the vertical dimension of the occlusion has been made. When the dentist is satisfied with the try-in, the wax partials are returned to the technician for the laboratory work to be concluded. The first stage is for the dentist to mark on the models with indelible pencil the mucogingival line. When this has been done, the dentist, and not the technician, should cut the teeth off the models. He should trim the stone to the shape that the subsequent surgical removal of the teeth and the alveolectomy will produce in the patient's mouth. It must be remembered that room must be provided for the labial flanges without causing forward displacement of the upper and lower lips. When this modification of both the models has been completed, the technician can continue his work by setting the anterior teeth. To assist him in this task, a duplicate model of the existing condition is helpful. In this case, the position of the anterior teeth has been modified slightly to improve appearance. When the setting of all the anterior teeth has been completed, the denture should be processed in acrylic resin. However, before this is done, it is necessary to make clear acrylic resin templates to both upper and lower models. These are necessary to indicate, during the surgical procedures, the shape to which the models have been trimmed, so that the removal of bone will be approximately the same. For these templates to be made, it is necessary to duplicate the trimmed models. The templates are shaped in wax on the duplicate models and then processed in cold cure, clear acrylic resin. Following this, and the processing of the dentures, the patient is brought in for the necessary surgery to be carried out. in this case under general anesthesia. Surgery can, of course, be carried out under local anesthesia in appropriate cases. The first stage in surgery is to make an incision through the mucoperiosteum, commencing at the distal aspect of the left upper canine and continuing across the gingival margins of the standing teeth to the distal aspect of the right canine. This incision is now being carried out. Next, the mucoperiosteal flap within the area outlined by the incision is reflected upwards, exposing the underlying bone of the outer alveolar plate. A periosteal elevator is being used for this purpose. When this part of the operation has been completed, the upper anterior teeth are removed carefully with forceps. The next procedure is to remove as much of the alveolar bone as will be necessary to allow the upper denture, with its labial flange, to be fitted successfully. The shaded areas on the diagram indicate approximately the amount of bone which is to be removed. Initially, bone is removed with bone forceps. Final smoothing of the bone surface is done with a burr. The mucoperiosteal flap is now placed back into position. Now the clear resin template is fitted to the upper jaw. Any areas that have not been reduced sufficiently to allow the plate to be fitted correctly will be visible through the transparent template as blanched areas of mucosa. If any such areas are noticed, further bone reduction must be carried out. If the fit of the template is satisfactory, the labial flap is sutured to the mucoperiosteum of the palate. With the completion of suturing, bleeding is controlled and the upper denture can be fitted. Similar surgical procedures are carried out in the lower jaw, and the lower denture is fitted. No check on occlusion, however, can be carried out until the anesthetic tube has been removed and the patient has recovered consciousness. The day after the teeth have been extracted and the alveolectomy performed, the patient must be seen to make sure that she is reasonably comfortable with the dentures, that healing is proceeding normally, and to make any necessary adjustments to the occlusion or peripheries. Both dentures should be removed and the alveolar ridge is examined. Healing appears to be good in the upper jaw, but a small pressure ulceration has developed in the labial sulcus in the right incisor region. Healing in the lower jaw appears satisfactory. The occlusion should be checked with blue paper, and any obvious premature or heavy contacts reduced by selective grinding. At the same time, the periphery in the right upper incisor region can also be reduced. After 6 weeks, Mrs. Dixon reports that although the upper denture continues to be satisfactory, the lower denture has become progressively looser. It is quite common to find that this has occurred to a greater extent in the lower than in the upper jaw. Inspection shows that there has been quite marked resorption of the anterior part of the lower alveolar ridge, and the denture is consequently unstable. The recommended treatment is to apply a functional impression material to the lower denture. This is placed in the fitting surface, and the denture is seated under occlusal pressure. Any gross excess impression material must be removed from the flanges and peripheries before the patient wears the modified denture for 48 hours. At the end of this time, the patient reports that the retention and stability of the denture has been improved. The new fitting surface, developed by the functional impression material, must be inspected carefully. Should the material have been displaced completely from any area, then the acrylic resin-based material should be reduced in that area and a fresh layer of impression material applied. Should the impression surface be satisfactory, then a model should be cast into the denture immediately to minimize the possibility of distortion of the impression material. Rebasing of the denture is done as quickly as possible, and the patient should now be able to continue for several more months before rebasing, duplication, or new dentures will be required.